Today, we're going to talk about psychosis and other relatively serious psychiatric adverse effects from trazodone. And I say yes, trazodone, because the reason for me producing this particular talk is that I've seen a few cases in my consultation career where very obviously psychosis was produced by trazodone, which was always prescribed for insomnia. Insomnia is a very, very common problem, and it's one that often attends a large number of mental illnesses. So trazodone, when thinking about pharmacotherapy for insomnia, trazodone looks very attractive because it's not a controlled substance. It's not, so far as we know, associated with longer term negative outcomes like increasing the risk for dementia, for example. And it's relatively safe in overdose. I put an asterisk next to that statement because there's actually no such thing as a safe overdose. But if people do take excessive quantities, it's unlikely to be lethal or produce irreversible damage. But again, not the same thing as safe. So all these factors together make trazodone a really popular medicine, incredibly popular for a medicine that is generic and has been on the market for 30 plus years. It still, as of 2017, was said to be the 30th most commonly prescribed medicine in all of the United States, and is like number 2 or number 3 in medicines that are recommended for insomnia. So tremendously popular medicine. Problem would be that, as I said, insomnia is very frequently accompanying mental illnesses, and anybody with any form of mental illness, I think we should cautiously think of them as people that have nervous systems or brains that might be more sensitive to adverse effects of any kind. So when we're prescribing a medicine which is inherently psychotropic to people that might have higher levels of vulnerability, that could be a recipe for difficulties that I think might not be appreciated so much if given the frequency that trazodone is recommended with. So a few words about trazodone. Like I said, it's very old medicine. It came out in the US market in 1981. It is complicated pharmacology. It fits into a category called SARI, standing for serotonin antagonist and reuptake inhibitor. There's a diagram on the right showing that. I'll narrate the diagram a bit. At relatively lower doses, you primarily are blocking the 2A subtype of serotonin receptor, which is not inherently beneficial, but FYI, the 2A subtype of the serotonin receptor is the primary target for LSD. So overactivity of the 2A might be a problem. And in fact, 2A or other kinds of serotonin subtype stimulation from SSRIs might be a reason why we occasionally see psychosis as a side effect from medicine, from the SSRI kind of medicine class. So lower doses block the 2A receptor. They do, although not producing direct mood benefit, blocking 2A receptor does promote sedation, and that, along with histamine H1 blockade at lower doses, probably accounts for the sedating side effect, which makes it easier for people to fall asleep. At relatively higher doses, trazodone blocks the serotonin reuptake pump and then functions like a standard serotonin reuptake inhibitor. So you have a dual action drug. And if you want to cast this in an optimistic way, you can say that at higher doses of trazodone, at standard antidepressant doses, you're getting the theoretical benefits of a SSRI. You're blocking some of the signal whereby some side effects might arrive, and you are, if you will, channeling serotonin into the 1A signal, which, to be very simplistically, would be, the happy channel, or the channel that produces some mood improvements. So that's trazodone. Like anything that works in the body, any medicine, in particular medicines that work with neurotransmitter systems, it comes with the potential for side effects. Um, it amazes me that in the United States, we can still get patents for medicines that are as old as Trazodone, but so is our patent law. So this is from prescribing information from a patented product called Elepro. I included here just to show you, like in the right column, what are some common side effects from insomnia level prescribing of Trazodone. Somnolence, obviously, headache, dry mouth, dizziness, and so forth. These are common side effects. Trazodone is also associated with a couple of sort of well-known but less common ones. One, across the board, antidepressants get a class warning for the potential to increase the risk for suicidal thoughts or behaviors that might be part of the serotonin 2A receptor activation that you get from SSRIs. Just me speculating. And then you have a very low risk. If my memory is right, it's about 1 in 10,000 cases of priapism, which is a sustained erection, which can progress to tissue damage and death. So it's a low risk but very serious complication. Again, Trazodone just happens to be known for that. There are others, but these are the ones that I think people know about. But what about things like mania? In my talking with psychiatric prescribers, I get the impression that many in the community sort of forget that Trazodone is an antidepressant medicine. I mean, it's a common conversation with a clinician that I should be cautious with an SSRI in my patient with bipolar disorder because antidepressants can provoke mania or cause a first episode of mania or make mood switches more likely or more frequent. But lots of times people with bipolar disorder are prescribed Trazodone to try to help promote sleep. And literature says that you do have a risk for developing mania. Here are some case reports that have been published that document mania that is induced by Trazodone. In many of these cases, the mania came very shortly after Trazodone was prescribed. And in many of those reports, the mania was treated with other medicines unsuccessfully, and then within a few days of Trazodone being discontinued, the mania abated. So these are by and large credible reports of manic episodes induced by Trazodone. The point being, it can happen. Terrao and colleagues made this observation, which I thought was particularly worth repeating here, that in comparing patients that were treated with Trazodone versus those treated with fluoxetine, aka Prozac, mania was more common in the Trazodone treated patients. So word of caution. And then the thing that got me interested in this is I've seen some cases where very clearly psychosis was caused by insomnia doses or sleep promoting doses of Trazodone. And my observations are not alone. Here are some other reports in literature of psychosis being caused or exacerbated by Trazodone. But drugs are tricky things. What's true maybe for a majority isn't true for everybody. And I think it's worth noting that Pierre and colleagues observed that Trazodone did seem to alleviate auditory hallucinations in some people with psychosis. And I won't get into these details in this talk, but there is some evidence that one of Trazodone's, the metabolite we're going to speak of next, in people with schizophrenia might paradoxically reduce psychosis symptoms, whereas in people without schizophrenia, it may worsen it may produce psychiatric side effects. So on to that. Why, on to a next topic. Why exactly Trazodone can produce mania or psychosis? We don't have enough data to say with great certainty, but I think it's worthwhile just letting you know about this compound called metachlorophenylpiperazine. There's my chemistry bachelor's degree, finally proving its value. But it's abbreviated to MCPP, and MCPP is a metabolite. It's like a first metabolite of Trazodone. Trazodone in the body will interact with cytochrome 3A4 and be converted into there goes my chemistry degree, metachlorophenyl MCPP. And estimates say that in some people up to about 1/10 of the dose of trazodone will be converted. I mean, 1/10 of the serum levels of trazodone will be represented as MCPP. MCPP is a very interesting compound. It's used in human laboratory studies to sort of probe the serotonin system. In some ways, you can think of MCPP as kind of like an anti-Prozac. It tends to produce anxiety, panic attacks, depression, agitation. There are some reports of it producing insomnia. Oddly to me, MCP made a debut in Europe in the late 90s as a drug of abuse. Apparently, it's in the illicit drug supply in the United States as well. Reportedly, some people like how it makes them feel, but also reportedly, most people don't like how it makes them feel. It produces, in people who use it, headache, anxiety, confusion, and depression. Also, in human laboratory studies, MCPP exacerbates symptoms of OCD. And going back to the 3A4 conversion, word to the wise, carbamazepine or oxcarbazepine, tegretol or trileptal are strong inducers. Also, St. John's wort is a moderate inducer. So if you have patients that are taking these drugs or that herb, odds would favor that they're going to be better able to produce MCPP. MCPP is a drug that sticks around in the body for, we'll say, 12 hours. And it's metabolized by 2D6. The 2D6 cytochrome is strongly inhibited by some other commonly used psychotropic medications, among them bupropion, aka Wellbutrin, citalopram / Celexa, fluoxetine / Prozac, and paroxetine / Paxil. And duloxetine is a moderate inhibitor of 2D6. So patients who are taking these drugs, we could reasonably expect will have higher levels of MCPP, and it may persist in the body for longer. In one relatively recent case that I encountered, there was a young man who was taking trazodone, and when his Prozac was increased, he had just an extraordinary provocation of anxiety and dysphoria. So it might be the case that the addition of the strong 2D6 inhibitor boosted MCPP levels in this particular case. So to be clear, mania, psychosis, and severe psychiatric side effects from trazodone are probably uncommon, but in a drug which has millions of prescriptions, those cases are no doubt out there. The exact mechanism remains to be determined, but this metabolite MCPP, I think people who prescribe trazodone should know about it because it is a definitely biologically and psychotropically active metabolite, and its psychotropic actions are in many cases opposite to the actions of antidepressants or drugs that we might use therapeutically. So it for some people functions as an anti-therapeutic metabolite. And although nobody has written about this formally, given the pharmacokinetics of MCPP, we should be especially cautious when we're prescribing inducers of 3A4 or inhibitors of 2D6.